Dr. Wahid Idriss presently from Saudi Arabia. I'm proud to be an alumni of this hospital. I took my training here in August 2013, and I would like to say that I've been doing laparoscopy since 1970. I was involved in my the first case of laparoscopic tubal ligation that was done at Columbia University, St. Luke's Hospital in New York. I was also involved in the first submucous resection in 1974, also in the same hospital. But if you are such an old timer and doing laparoscopy over so many years, eventually you tend to carry very bad habits. And I came back here to correct these habits. Anyway, I'm talking a little bit about infertility in my present practice at this point. This paper is coming from two hospitals. One in Jeddah, Saudi Arabia, in a hospital called Idriss Hospital, established in 1946, and we started IVF over there in 1992. Also in 1995, we have another center in Homs, Syria. Now this publication comes from the two centers. My aim in this paper is to write about endometrial cavity evaluation prior to IVF transfer, embryo transfer, timing and effect of mock transfer. Mock transfer is simply a practice transfer that you like to practice as if you were doing ET at a different time. Now, in my opinion, and after so many years of experience, I find that embryo transfer is the single most important factor in a successful IVF program. And way back in New York, people were doing mock embryo transfer during the period of the patient on day 3. And later on, people tried to do it at day 6 or 7. But in our case, I'm trying to prove that you can even do mock transfer at the time of embryo transfer, of oocyte retrieval. So evaluation of the endometrial cavity is simply vaginal ultrasound in all cases, whether failed or beginning, and sonohistogram, as well as hysteroscopy. Any patient that we see any abnormalities in the vaginal ultrasound, we go ahead and do sonohistogram or hysteroscopy. But all patients who present to us with a failed cycle of IVF, we straight ahead go for hysteroscopy. Now this is a very simple, normal hysteroscope. This is the cavity before giving the saline. This is an open cavity, and this is uterine cavity. And this is one of the ostia. So every patient has to go through this if they have failed previous cycle. And this is the form that we look at. And the most important thing that we consider very essential is the angle. The angle that connects the cervix to the uterus. So in some cases, it's a very acute angle, and that prevents easy transfer. This is one sample of IVF, and people who were fighting to have successful cases back in the 90s were always worried about this step of embryo transfer. People have tried all sorts of methods until they have reached the right way. The most important thing, I guess, is the experience of the doctor who's performing the operation, and that the patient is very relaxed. So I consider to be the most important step in the procedure of IVF-XC. A successful ET is related to the ease of transfer, position of the endometrial cavity, I mean angulation, and with minimal manipulation. The more manipulation we have, the worse results we have. If we touch the cervix, we might not succeed in this, in improving that cycle. So this is a relative study. See, doctors who keep on doing embryo transfer, 42 physicians in this study were asked who are actually performing embryo transfer almost on a daily basis. The physicians were asked to rank these factors from 1 to 10. The first is the removal of hydrosalpinx. They consider this the most important step to do. Absence of blood on the mucus, on the embryo transfer catheter. Type of catheter. And not touching the fundus. But in my opinion, the most important one is not using a tenaculum. Using a tenaculum will just stimulate the uterus to produce contraction, and then you fail. Leaving catheter in place for 1 minute. Trial transfer, which I'm talking about, the mock transfer, in my opinion should be number 2 or 3. Ultrasound monitoring during the cycle. All of these factors are very important in a successful ET. ET versus MET. MET is mock embryo transfer or practice embryo transfer. To access the cervix, to measure the uterine cavity, to find out the position, whether anteverted or retroverted. Ease of transfer is very important. And finally, the most important thing is discovering true or false cervical stenosis, which is really frustrating and will lead to failure of the case. Discovering angulation of the cervico-uterine junction is also very important. Now, timing. Obviously, people were doing mock transfer, worried about the endometrium. They were doing it very early. I remember back in New York and Boston, they were doing as early as the 3rd cycle. But I thought of doing it at the time of retrieval, because it will save you time from doing 2 procedures in the same cycle and lessen the anxiety of the patient. So she doesn't have to do a mock transfer and another procedure in the same cycle. Now what we use Candel Tomcat catheters. People who have old experience and know that Tomcat was a catheter that was used back in the 90s. So we use this only for mock transfer. We can use Tomcat 4.5 open-ended or Tomcat 5.5, either one. Of course, 4.5 is more rigid and you can enter easily the cervix. What are we doing? We are measuring the position, anteverted, retroverted, and we want to know the sounding, how big is the cavity, and to access the angulation. Now, how do we deal with a difficult mock transfer or impossible transfer? We use Laparoscopic speculum, which is a German speculum that I will show you a picture later on. We use a posterior tip lip tenaculum. Sometimes we have to use laminaria to open up the cervix. And we try to diagnose cervical stenosis as early as possible. So in my opinion, a late mock transfer would be easier on the patient and the doctor. This is the Laparoscopic speculum, which has tooth at the end, and this is a posterior tenaculum. These are 2 catheters, Tomcat 4.5 and 5.5. 4.5 is more stiff Our population, we are reporting a population of that were done in Arab Fertility Center, AFC, in 2 locations. One in Jeddah, Saudi Arabia, and the other in Homs, Syria. Now, of course, all of these cases, Homs now became very famous on the media, on the CNN, but these cases were done prior to the war. At this point, the hospital, unfortunately, is not working. So these cases were performed 09 to 10. A total number of 657 cases, 466 had mock transfer at the time of oocyte retrieval, and the others had mock transfer at any other time, including during the period and right after the period. The protocol is a standard. We're using short protocol at that point: ovulation induction, gonadotropin, and starting from day 3, and then using superfact or lupron as a downregulator. Aspiration of the follicle was done 36 hours after SCG injection, and when the 2 leading follicles reached 18 mm. Embryo transfer was done 3 to 4 days after oocyte retrieval with 2 to 5 embryos, using Cook, ET catheter or Wallace catheter. We have done few cases of 5 embryos, but mostly they were 2 to 3. Now these are the parameters of these studies: 2 groups, early MET and late MET, and oocyte retrieval MET. So the age is the same, 32, 33, body mass index the same, ICSI 40% in early and 86 in OR, oocyte retrieval group. Peak estradiol was almost the same, 1.5, 1.8. Mean number of oocytes, 8 and 9. Mean number of mature oocytes, 6 and 7. Mean number of embryos, 3 and 4. Mean number of embryo transferred, 3 and 4. So they're almost the same group. Difficult transfers were 23%. In some cases, we had to use laminaria or postpone the case and freeze the embryo, which is the best thing to do if you have a freezing program. Mean length of the cavity at MET is 7.5, and the depth is 7 and 7.2. Now the pregnancy rate, or positive pregnancy test per embryo transfer is 34% in early group and 36% in that. Clinical pregnancy, 30 and 32. Ongoing pregnancy rate, 21 and 23. So little difference. Now, in 2008, something new was used in IVF, which is during the procedure to follow the case by vaginal ultrasound, which is very cumbersome, and this practice was introduced by a famous doctor in New York called Dr. Nabil Husami, a very good friend of mine. So the catheter is put, and he removes the speculum and put a probe, a vaginal probe. I personally prefer abdominal probe during the procedure. Transvaginal improves the outcome of patient, and Husami and the group, but unfortunately these are unpublished data. Summary: our study shows that timing of mock transfer does not affect implantation or pregnancy rate. We recommend strongly that mock transfer should be done at the time of oocyte retrieval in most cases, and done early in selected cases to avoid the cervical stenosis and avoid severe cervico-uterine junction. And thank you very much.
Thank you, a nice presentation. One thing I wanted to ask, if we do milk transfer at the time of OPU, so it won't disturb the endometrium. Because here in India, we practice either day 2 of the current cycle or day 21 of the previous cycle. We don't do at the time of OPU.
That's a very good question. Actually, when we do mock transfer at the time of oocyte retrieval, we don't really enter into the cavity.
Okay.
We just go to the cervix.
Okay. So you don't touch that.
Yeah, I'm very worried avoiding to go into the cervix.
Okay.
But sometimes you end up having a stenosis and you cancel the case and try. Of course, before doing that, we use a tenaculum. We use this speculum that I showed you, and but the pregnancy rate goes down.
We do on the day 2 and they say if it gives some endometrial trauma, that will result, increase the relative pregnancy.
Yeah.
If there is some endometrial trauma in the day 2.
Correct.
Then we touch the endometrial trauma.
In my cases, I'm doing it at oocyte retrieval.
Yeah, so no endometrial.
Without entering into the endometrium.
Any other question from the house?